Yeah, after all that we've been focusing so much on fat, and it's so important, and it does things nothing else can do, but I don't use it a lot during facelift. I use it some, so I'm a little different in that sense, and I'm going to share that with you. And everybody gets fat to the lids and the lips, the expressive facial features, but I like to handle my fat for the face a different way, and then if we need it, yeah, then I do it. So that's different. I want to spend a little time about the mouth because I don't think the mouth gets enough time. So with resuspension of the mouth. So that's what we're going to do. Architectural restoration. I don't have any conflicts. And so what are the goals? That's worth going over for a minute. When I went into practice, neck was first for me, then face, eyes, mouth, surface. And in 1980, when I got turned loose on the public, and the neck is still the most powerful single thing you can probably do. But the face came ahead of the neck in 95 when I was doing mid-facelift and getting some big curves, and then eyes and mouth got ahead of the neck for me. And most recently, I realized the mouth is probably more important than the eyes in most situations, which brings me sort of to today. And then, so I'll run over it. I think facial architecture is number one, and the lower facial curve down low is more important than what you do up higher in the cheek. And our first assessment of a person's face, age, vitality, health, beauty, occurs as an instantaneous snapshot, and it's largely based on facial architecture, and it's done unconsciously. We learn to do it in early age, and so it remains unconscious until we're taught to see it again, like a lot of things we do unconsciously. Number 2 and 3 for me are the expressive features, and I probably uniquely place the mouth ahead of the eyes. And mouth position is much more important than the lips, but with respect to the eyes, I feel equal importance for the upper and lower orbit. I don't think there's any difference between the two. More often for me, the mouth is number 2, the eyes are number 1, but sometimes it's just the opposite. The eyes number 2, the mouth number 3. After that unconscious snapshot, we more deliberately assess the face, and we feed the information to our brain by scanning rapidly across the face, and Brian tells us that in his new book, usually starting with the mouth, then moving up to the eyes. So that's a vote for the importance of the mouth and things. In terms of cervical architecture, well, the jawline might be a little more important than what's going on with the underjaw, but the neck remains critical in overall facial rejuvenation. But it must be remembered that when people meet, they meet face to face. They don't meet neck to neck. So that alters my thing. And the surface is extremely important. Skin redundancy, wrinkle spots, it's all important, of course, isn't it? So, but that's just my list. So architectural, what do I mean by that? Volume neutral, not adding anything to the face, or reshaping the aging face in the safe, simple, superficial subcutaneous plane with the tissue that's there. In the old-fashioned plane, that also is a lot more powerful than most people recognize, and it's simple in its anatomy and technique. So here, yeah, just like Ted, I got my guy up there, no respect for the word superficial and facelift, and it's true, there isn't. But I've done hundreds of facelifts in each of the 3 planes, subcutaneous, mass, subperiosteal. I returned to this sub-Q years ago because it's the most powerful for reshaping facial architecture, which for me is the most important thing we do, especially lower, jowl and lower face. And it's also the best for resuspending the frontal commissure, and which is the most difficult thing we try to do. It also is very powerful for resuspending low mass, which is a little bit surprising, and for redraping this paramedian skin redundancy because I have to undermine further than others, and the longevity results. Now that's counterintuitive, and I have to justify that statement. I know I'll try to. And then for ease of reoperation, of course, it's not unlike the SMES circumstance. Reoperation adds almost nothing in this particular scenario. So the universal ideal. Well, it's an inverted cone of youth with graceful, curvilinear cheek profile. And I've had to add more recently because there's so much fat grafting in a delicate jawline. So those are the attributes of a beautiful youth. And the hen's egg, yeah, makes a pretty good metaphor for that. And on its narrow point, we have the inverted cone of youth, and on its broad point, the squatting cone of age with jowls, famously egg foo young, egg foo old. So I'll use the eggs to keep you thinking about this stuff. And it's not the first time an egg's been used. A lot of the great masters used them in the triptychs throughout the great cathedrals of Europe, always above the Virgin's head. It was the way of conveying to the unwashed that Mary reflected nature's divine anatomy and the divine architecture. Now, when I look at a scale and I balance strategically the concepts of suspension, traditional facelift, versus newer concepts of augmentation, my scales fall decidedly toward the suspension side in the traditional way. I only do fat grafting in 25% of facelifts to the face itself. Now, what about when I'm looking lower down at an area of excess, like the jowl? Well, it's the same thing. It's suspension that is overwhelmingly important in my book, and not reduction, which I do in only 2% of patients, where I reduce or take fat away from the face. So I'm a traditionalist in that sense. So architectural facelift is superficial subcutaneous on block, non-smash, stacking, and tension-free stacking, by the way. Of what? Well, of the lower facial redundancy that we call the jowl. Where? Well, higher up in the submalar midface. It doesn't reach to the malar, but the submalar zone, with the option of adding some more fat to the cheek if you like, or taking a little fat away in 2%. It's on the superficial plane as a low transverse plication. It fills the submalar deficiency. What's it fill it with? It fills it with the jowl, which is lifted up there, thereby emptying the jowl. It elevates the commissure, defines the jawline, and it corrects the neck in many. And it tailors the skin with the attendant wide rhodectomy. It's been my basic facelift now for a little over 20 years, and my initials happen to spell my monogram spells jowl, which is the focus of facelift for me. RSVP is the name of it. Restorative subcutaneous vertical paramedian lift. Everything's up front and it's vertical. RSVP. You got to have a fancy whatever you call those things. So just to look a little bit, the focus is on the jowl and the commissure, the 2 most important things in facelift, JC. So there's first a fallen cheek volume, and there's typically a commissure slump with it, and many times bitterness folds associated with the slump of the commissure, and many times marionette lines, and typically a segmental jawline ptosis. What I don't buy into is pre-jowl depression. At least I almost never put fat there unless I fail in my primary mission. Now there's attending this is nasolabial fold, upper lip lengthening, chin pad ptosis, lower lip ptosis, exposing the lower teeth, submental plane ptosis, as well as the presentation of bands. Those all go in concert. This doesn't occur in a vacuum, and then associated with that typically submalar fattening and deficiency. This is the last case I didn't put fat in the face, and it was the year 2000, JC. It's not a religious reference, jowl commissure. And every case since then I put fat in, and you can see that her upper eyelids are a disaster. I'm starting to sound like Trump. And but if you cover up her eyes, it's pretty good. So that was the year I also figured out upper eyelid grafting from my perspective. But ever since then, I put fat in the lids and lips of every facelift. Now, a little kid plays a trick on the father, puts the pillow in the middle of the bed. The guests are going to put their coat there at the party that night, and he figures that father won't know what to do. Well, he doesn't know what to do. He sees it, he panics, he calls his friends, he says, "Get over it, guys. There's a bulge. My wife's going to kill me when she sees it. We got to get rid of it." And they try their best, pulling on the spread, whatever. The housekeeper knows what to do. Fortunately, she hadn't left, and she unmakes the bed past the bulge, which she delicately repositions where it came from and where it belongs, gently, and then she remakes the bed. Okay, unmake the bed, reposition the pillow, remake the bed. That's my mantra. Undrape the face, reshape the face, then redrape it. And we follow that in a lot of things. That's a common thing in breast and all that. Well, it makes sense in the face. Now, we've had some recent anatomic insights into this pre-master space by dear Brian, who's contributed so much to us Waffle Woos, their colleagues. And just like there's a pre-zygomatic, we know there's a pre-master space. It explains why the jowl falls down, why it is so ubiquitously present in the aging face. And it also explains that it shouldn't require release. If it fell down in the first place, it should be resuspensible without release, which it is by nothing more serious than 5-O-Vicryl, which I used for 15 years. So here's the basic lift, RSVP. It starts with undraping the face, unmaking the bed. Mark the jowl in the sitting position, then mark my limited facelift incision. And I've never used a pre-treacle, and I don't use retroauricular or submental incisions any longer. That's another story, and there are arguments on both sides of that. But I don't. And but I undermine out to the commissure and everybody if I'm doing a regular facelift. And down in the neck for a problem neck as far far as you see here. So that's freeing in the superficial subcutaneous plane. And then I said about reshaping. Well, in half of them, I'm going to take out the submental fat. And then I divide the platysma in 80%, as you see right there. And then in 95%, I'm going to suspend the platysma with a posterior suture, and another 80% cinch it posteriorly. But the reason I'm there in everybody is for the lift. So I begin by marking a blue line on the fat, on the bottom of the nose, the bottom of the ear, and then assessing how much redundancy or how much movement there is below it. And once I've drawn that second line, I just sew it up rapidly with running 4-0 PDS, one line to the other. And what I do up front is very important. What I do back in front of the ear is really of almost no importance. And just so there's no doubt of what it is to put a suture in fat above and a little fat below, I'll show you one stitch without insulting you, I hope. There's just a bite with 5-0 Vicryl for years. I used interrupted 5-0 Vicryl more recently running 4-0. Why did I kick it up a notch? Because it's a running stitch, and I don't want it to break and have everything fall apart. So you just take all the redundancy out of the system, but stop short of trying to create tension, which is wrong in many regards, and we'll get into that a little bit more. And then you tie it up. And people say, well, you can't sew fat to fat. Sure you can. If you avoid tension and you're delicate, you have basic plastic surgical skills, you can. And it sews up just like that. So that's what it looks like to take a piece of fat and sew it to a higher piece of fat. There's nothing special about that. And then instead of doing that interruptedly, I now simply run that out toward the ear. Pretty simple. So that's the RSVP lift. It's anterior, and it's short, and it's vertical, and it's quite different from the other vectors and positions. I remove fat, as I mentioned, in 2% of patients, some fat from the residual that's left of the jaw, so I don't do that very often, but I divide the DAO in everybody, and that was Claude Laurent's idea first, not during facelift, but as an intraoral procedure. And then I lift the modiolus with a 4-0 nylon and plug the gap with something from the discard specimen. So it's a facelift, but with a lot of emphasis on the mouth. And then I redrape the face, of course, with the same avoidance of tension. So this subcutaneous enema, I'm just going to compare it with a couple of the guys here in the room and some others as well. That's what Patrick leaves undissected that I dissect right there, and that's what Baker leaves undissected. He doesn't go there, and Jim Snoozen doesn't dissect that. He leaves that undissected. And of course, Tim, more than any, believing strongly that he can't break that anatomy there, leaves that undissected. So that's what I'm dissecting that where others don't. But that's a safe zone. It's beyond the thin danger zone and in the zone of rapid dissection with outside any perforated support of the tragus. And it's my gateway, really, to most of what I accomplish. It's my sub-Q access to the paramedian face. So it allows me to divide and graft the DAO. We suspend the modiolus and commissure directly. We suspend the jowl and marionette directly and redrape the paramedian skin that often accompanies aging. So I'm not going to give that up. So I want to be upfront with you about facelift, and literally upfront. These are the two most important sutures in facelift, at least they're the two most important sutures in my facelift, JC gel commissure. And in order to place those sutures way up front of the face like that, I got to make room to get there, so I've got to do a subcutaneous undermining. So the second part is wide undermining to get to the commissure to be able to do that key movement. So let's look at it a minute. The two steps, wide undermining, anterior plication. What's the asset of the undermining? Provides access. Access for paramedian work, vertical, I hope. And direct jowl sculpture, 2%, which you trim down with the scissors. But division of the DAO and hitch of the modiolus in virtually everybody. And it increases the rhodectomy effect, which is a good thing. It redrapes the skin clear from the commissure. And it improves the nasolabial bitterness and marionette folds to a degree that I couldn't otherwise accomplish. There's a theoretical increase, I guess, to hematoma necrosis because I've undermined slightly further, but I think that's theoretical. In terms of the anterior, what's that about? Well, it eliminates the jowl. It doesn't just improve it. Fills the submalar deficiency, effaces the nasolabial bitterness fold, eliminates the marionette line, corrects the jawline, suspends the underjaw, reverses the platysma banding to a degree, and suspends the modiolus of the mouth. It does all of that, and there's no liability to doing it. Once you have access, there's no reason not to do it there. So I transfer all of these worthy enemies for the aging face onto a map of the face, targets, if you will, and they all have something in common. They share a common geography. They're all paramedian. None of them are back in the face. And I like to subject them to a vertical vector. I don't do anything in the paramedian region of the face. I do something in the posterior neck, but not in the face. So paramedian. All right, when Willie Sutton was asked why Rod Banks, he answered, of course, because that's where the money is. So if any of you ask me why I'm doing all this work up front in the face, my answer would be because that's where the aging is, like all of it. That's where all of our aging markers are. And why vertical? Well, I favor a vector for rejuvenation that runs perpendicular to the core of the earth. That's sort of sensible to me, and I think it's an important distinction. This guy here is my authority on it, and it's not unimportant. There's as much difference between a vertical and an oblique vector as between a oblique and a lateral vector. We just heard from Tim how bad a lateral vector would be, of course. So I believe that now my skin vector is vertical oblique, and my lateral platysma and my brow vector is vertical oblique, but every other vector I use in the face is purely vertical. And to use a little nautical analogy, I believe in face lift, not face list. So I'm strictly a vertical thinker here. Now we tiptoe around this word a lot, and I want to ask you to step out of the tension box just for a minute. You heard Tim said he doesn't feel he relies on tension, but an awful lot of people doing this work do. And primary goal of RSVP lift is to alleviate the lower facial soft tissue redundancy that accumulates over 40 to 70 years here on Earth at 1G. And I define redundancy as the distance that you can move your soft tissues until tension sets in. That's the T word right there. And tension's not bad. I've used tension all my career in plastic surgery. It increases the movement of the tissues you want to move, and you can move them longer distances because it increases the power of suspension. However, it comes at a price. There may be increased unnatural, as I say, in unskilled hands. There's definitely flattening of soft tissue planes when you embrace tension. And without a doubt, you increase the force for recurrence of the deformity because that's Newton's third law. For every action, there's an equal and opposite reaction. And it shouldn't surprise us that the results are subject to the laws of nature and physics. They are. So it requires rigid fixation, which everyone pretty much agrees to. Let's say you did a facelift without tension, however. What would change? Well, you might have more natural results. I don't know. But there'd be less tendency to flatten, that's for sure. And there's less force for recurrence of deformity. You're left really fighting gravity only. So it requires only a fluid or a non-rigid fixation. You can sew fat to fat, even though the upper fat moves a little bit. Not a problem. What's the liability? Well, you can't move it as well with as much strength. You can't move it as far. So you better work close to what it is you're trying to move. So my plication line is quite close to the jowl. It's an inch away. Now I'm going to focus on fluid a minute. Now this gets a little sophisticated, but we got a sophisticated audience here. And when I wrote this paper, I was doing facelift in two planes. Now I've given up the subperiosteal. But I acknowledged in that article way back then, as I'm sewing the fat together in my non-rigid fixation in the subcutaneous plane, when I tie that, you can see that I have indicated a downward movement of the upper subcutaneous block, which occurs. I'm acknowledging this isn't rigid fixation. It turns out that it's quite a good thing, but most of my colleagues have looked at it and said, well, that's a weakness. It's not. And this is also not an unimportant distinction. In Denver in 2011 at a facelift panel, you look at that woman's upper cheek a minute, and I showed that case, and the chairman says to me, well, you did something upper cheek, didn't you? I said, no, I didn't. But you have to understand it's not a rigid fixation that I used, but a fluid one. So let's understand that a minute. All the sutures was limited to that dotted line. The fluid fixation resets the subcutaneous curve of the upper cheek into a pleasing long radius arc or dome, which is the shape of the lower surface tension, automatically in the semi-fluid environment of fat. Again, it shouldn't surprise us. We're subject to laws of physics and nature. And all of my patients show that change of the upper cheek, even though none of my manipulation is above the base of the nose. And none of these patients have had any fat grafting. They've had no manipulation to that point. It's happened happens simply because the fixation is fluid, and physics sets this semi-fluid layer into a prettier curve, and it does it automatically. In fact, it does it a lot better than I could do it. So the fluid fixation automatically resets the malar curve, and I don't need to get into that and figure out how to do it. And you look at the bumps all over this woman's face. The only thing she's had done is she's had her pillow lifted up to the level of the base of her nose. She hasn't had a suture placed anyplace else. She hasn't had a drop of fat. It all just happened automatically following the laws of nature. Now, rigid fixation may not be the same. A rigid fixation does not automatically create a natural pleasing curve. And these were the results from 3 facelift papers published in the same journal that same year that was published. And every one of these results is a little strange. These are not curves of nature. These are curves of man. So I want to stay on this a minute, architecture. And because my approach I consider auto-architectural, restorative subcutaneous vertical plication. And that woman has 2 dents in her face. What's that? That's a double dip. And most aging faces have it. And after the surgery with no fat, she has a pretty extended curve. Same thing here. There's a double dip. And after the pillow's been put back at the head of the bed, she has a pretty extended, graceful curve. And so it is with all of these. I haven't done anything to those dents. I didn't mark them preoperatively. I didn't pay any attention to them. It happens automatically. Even on a young woman, you can see a double dip in almost all of their oblique profiles after a pretty early time in life. And none of these did I do anything other than lift my pillow, just like the maid did in that party analogy. And others, not always that way. This happens to be an ad for facelift, but she's got a bigger double dip after surgery than she had before. So that's not what I would call an architectural outcome. And here are just some quick results of people who you all know and admire, as I do also, but who don't see this maybe as much as I see it. And they've all created or exaggerated double dips. And this is not what I recommend. This woman doesn't look bad. That's not a bad double dip. But after her surgery, it does look bad. And so it's worse. And that's a shame. And we shouldn't be doing that. And people with these skills, because these are the top, are doing this. So this is happening, and we need to talk about it a little bit. That is not a pleasing facial curve. And it's not a youthful curve either. So I just show you a few of those from very skilled faceless surgeons. It's clearly off the radar. So let's keep it on your radar. So that's the oblique facial curve. Now let's go on to another topic, one that might have surprised you, because I claimed superiority in longevity. How can that be, working in the superficial plane? Well, longevity suspension. My rule is to work close to what it is that you're trying to move. So I'm an inch away from the jaw. And if you're studying material science, creep is proportionate to distance. The Golden Gate Bridge guys know that with their cables. When my lower blue line is elevated 3 centimeters, the jowl elevates 3 centimeters and stays there. Now when the superior margin of SMAS is elevated 3 centimeters, way up there above the arch, how far does the jowl elevate? Well, I'm going to suggest, politely, that it's probably a little less than 3 centimeters. Is there any evidence for that statement? Well, Geyer is unique among SMAS experts in undermining the commissure. And Bond will tell you that when he tests the soft tissues of the jowl after he finishes SMAS suspension, he finds uncorrected redundancy there, which he now, by KT, uses the term Taylor tack in the subcutaneous plane. He finds it regularly. Okay, so the SMAS didn't take care of it. And Joel Feldman originally performed a skin lift alone. He amputated the lower jowl, and later added the SMAS to sort of help the jowl. And then still later, he happened to go back and compare all of his results, and he will tell you that he found no difference between the two. And therefore, he returned for the last 15 years of his career to skin lift alone without SMAS as a simpler, safer, and equivalent procedure. So that's just a little, the preponderance of weight is all for the SMAS. So I'm going to give you evidence the other way. Most SMAS surgeons with fat grafting skills add pre-jowl fat, but it might prove unnecessary if the jowl had been resuspended. And the same thing with adding fat routinely to the cheek. If you've really got the jowl back up there, you might not need to add that, or maybe not as much. So just something to think about. What else? Well, creep is proportionate to load. We all know that. In our case, tension is the operative word. So I just remind you again, avoid tension during suspension. Newton. When the tension is minimized during facial suspension, Newton's reaction, which is the force for recurrence, is also minimized, leaving only gravity over time to recreate a lesser deformity. So let's look at some long-term results. But first, embrace the laws of nature. And they're great biomaterials for tensile strength. Flexor tendons come to mind, fascia lata, temporal fascia, all these things are great. The SMAS, however, lovingly dissected by Giovanni Botti, shows some holes and some missing parts. Well, the SMAS sure is better than skin or fat, but it doesn't compare to those other 3 up there. So it's someplace down there. But let's not treat it like the cables of the Golden Gate Bridge, which it's not. So my rule is work close to what you're trying to move and avoid tension when you're moving it, and then to embrace a vertical vector when you can, and finally to embrace a fluid fixation when you're working in a soft tissue environment such as the cheek, because you can have some advantages to that. Here's a 50-year-old who comes back 9 years later, and look at the jowl commissure in all of these. She's younger now at 59 than she was at 50, so that's holding up. Here's a woman, again, jowl commissure. Here she's 9 years later. Now, she's one I showed you in that analysis, and that's her a year after. Now let's look at her 9 years after. So she's 9 years after, and look at her jowl and her commissure. You can look at her facial shape too. She's 9 years older. She's 60 now. Here's a patient who comes back to show me her nose has been ruined with a cancer, and she's much younger, 10 years later. This woman's also 10 years later. She's a younger woman at 75 by a considerable margin than she was at 65 when she had her facelift. As is this woman, 60 years old now instead of 50 when she had her surgery. And again, focus on the jawline and the commissure. And now this woman's had secondary fat grafting around the eye. None of the rest have. So that's with some extra fat grafting, but the single procedure 12 years ago. Here's one 13 years afterwards. And yeah, she's got a little jowl showing up, but that's a minor skin issue. And if somebody wants to ask me how to fix that, I can tell you later. Here's a woman who's 60 now, and she looks younger than when she was 48, whatever it was, 14 years later. Or a guy who's younger at 64 than he was at 48. Nothing having been done anything except that one I mentioned. One fell down the stairs and had a stroke and was in a coma for 3 months. So she has a problem. But on the non-stroke side, her architecture has really held up very well despite the terrible trauma she survived and lived through at 16 years. She's really doing pretty well. And here's a woman who hated her fat face before and likes her thin face. You may not agree with her on that, but she's 18 years after her facelift. There's the slightest little something going on with the jowl that's simply minor skin relaxation. Here's one 18 years after, and this one I did before fat grafting. Now, I'm not going to say she's younger, but she hasn't aged a day since that procedure. And here's one 21 years later before I was fat grafting. And look at her nasal labia and look at her appearance fold markers. They're way better. Now you take off the sunglasses and her eyes are as old as the hills, as is her lower lip. But these things are holding up, and there has to be a reason for it. And I think it's the avoidance of tension. I don't have another reason for it. So back down making the bed, because oh, now this is going to jam here. Anyway, these are the 4 persistent paramedian pathologies of the aging face, and I see them as we all do in secondary. What's been left behind: nasolabial fold, bitterness fold, marionette line, skin excess, paramedian. My approach to the nasolabial is undermine over the nasolabial and take some fat out with microliposuction like that. If she's got a fold on one side, she's not going to be happy with a partial improvement. She wants symmetry. She's also asked for a narrow nose and chin, which I've done as an additional thing, but her fold is pretty good. And look at the bitterness fold with the commissure slump and the marionette line with the jowl. Well, since I undermine over to the fold, I can get my hands on those structures. I'm past the jowl, and that allows me to effectively treat both the mouth and the jowl in a way that I feel I could not otherwise do. So I'm defining my primary target. No fat grafts in any of these patients except lids and lips. And then skin excess. Well, skin's a big age. Here's a woman, she's only 55 years old. My God, you look terrible. And so I couldn't have gotten this result if I'd limited my undermining mid-cheek. I just don't believe I could have. So I like, although it's a little more time, a little more effort, I think there's some benefits that come. And because it doesn't ruin my operation, I do it. I understand why it's a problem with the SMAS approach, and you can't or shouldn't do it there. Now, nasolabial, just some other. Here's a standard average crease. And I don't suggest that I always have missing no nasolabial. I don't, but these are just 3 examples that were selected. No fat graft into the fold in any of these. Here's a deep crease where I'm not going to get rid of that, but let's improve it. And you're going to see her now 27 years before on her wedding day, and actually her crease and mouth and all that are better than they were when she was 27 years younger. So even though it hasn't been eliminated, it's been improved. And also for the etched line, again, I go into these cases with a very positive attitude about what the basic technique is going to be able to deliver. So I'm going to take you to a basketball game and talk about facelift three-point shot, because a lot of facelift lectures, not here today, but a lot of them we see slam dunks and free throws and two-point shots. We see easy shots. And one guy wrote in his evaluation, all of his pre-ops look better than any of my post-ops. That's another way of saying none of his patients needed a facelift. Well, the three-point shot and facelift for me is the commissure slump with bitterness fold, and it's present to a significant degree in a third of the patients that I see. Here are some done by famous, well-respected, admired surgeons, recent published results. Now that hits the backboard because there's been some improvement there, but it certainly doesn't go through the basket. And this one, you could say it was a missed opportunity and all of that. Yeah, hits the backboard. But some of these are not so forgivable, all top surgeons. So clearly this isn't on the radar. That's an airball, as this one is, because she didn't appear disapproving until she had her facelift, and now she decidedly is disapproving. And really, do we put a patient through a facelift to end up with this result and all that it entails? Well, remember, somebody was proud of these results. Now, is this impossible? No. Here's a case I did 18 years ago before he was fat grafting, and she's pretty good. And then 17 years ago or so, there's another one, and she's pretty good. And then fat grafting helps a lot when you add that to the mouth. So this is one of my first fat grafts of the lip, so we've done that, and now you get the benefit of a little more fat to the lip. And so it's awfully important. It contributes so much to the result. And this little business at the corner of the mouth that's so widely overlooked, that's a three-point shot. And notice that the commissure is exactly where it was before. It's not exaggerated in any way. So let's look at some others. This is a woman who's depressed. She was a recluse, and she had a terrible accident, nearly died, and aging too. And if you hadn't fixed her mouth, she still looked depressed. She's not depressed anymore, by the way. And here's a woman who had victim of some bad surgery, and she's just as sweet as can be. She doesn't look sweet, she looks nasty, and that's the power of the mouth. That's her mouth. That's her perioral personality, not the one on the left. We need to help these people and correct these things. And this is the one guy who asked me in my career the maximum change I could muster. I don't get that from men very often. Now, this woman you saw before, and here she is a year after surgery. She's sort of cute, and then she used to model. That's how she paid her bills before she met her husband. And then she has her facelift in her 50s, and then she comes back to show me 10 years later, and there she is with that thing on her nose. And I ask you, who does she look more like now? Her 20-year-old model self or a 50-year-old preoperative self? Well, she looks more like the model, and that's the power of the mouth. That's the power of the mouth. We shouldn't be overlooking it. We should be going after it. So let's talk about the mouth a little further. There are 3 steps that I think of. A stomopexy. What's that? Internal suspension, lifting the mouth. So there's stomopexy, of course, lip augmentation, and then, of course, surface treatments. And we won't get into those unless somebody has a question. But I encircle the mouth. I'm going to do subalar work, mucosa, commissure, modiolus, the jowl, the skin, the lateral platysma, the DAO, the medial platysma, the DLI, the mentalis. I'm going to tweak all of these things to try to get that mouth to rise. It's that important to me. Some of these are automatic. It's automatic. When I lift the jowl, I automatically improve the environment of the corner of the mouth, and that's the most important thing that I do, and it's intrinsic to my basic facelift with that 4 OPS. And because my skin movement is mostly, it's not vertical, it's vertical oblique, that also contributes, and that's automatic. And because in 80% of the cases I do, I divide clear across the platysma, which is an accessory depressor of the angle, that helps also. Those are auto for me. Now, these others are optional, but I embrace most of them in most patients. I divide the DAO, again, Claude Laurent first called that our attention, and that helps. Now, let me show you that on video. It's easy to do, it's not dangerous, I've never had a negative consequence. You put a needle through so you know exactly where the commissure is, stay within a centimeter of the chin's toward the left, and simply delve down with your electric needle. It must be an electric needle, not a cold blade, because if the lip twitches, you've gotten over the DLI and back off, so you have that safety factor. But you go through the muscle fibers that are there, and they are DAO, and if you want to go a little further, you can pull it out a little further and divide some of the platysma too. And you need to fill that. That has to be filled with something from the discard specimen, and now that I further hoist it up a little bit, it's a bigger graft than that, but you'll be sure you've got a graft left from what you take in front of the ear. So now I'm lifting the modiolus as well to get a little more effect for some years now, and these things don't take very much time. I've got the time down there, and I lift the chin pad. I lift that because it repositions the mentalis origins and helps support the lower lip. And I release the DLI in almost everybody. You mustn't cut it. You mustn't damage it directly in any way, but to release it subperiosteally is fine. I also release the medial platysma, but only if I'm cutting the platysma clear across, because if you would release that without cutting the platysma, you have now created another depressor of the angle, and you've shot yourself in your foot. Now, the mucosa hitch is taking mucosa off directly above, and I do that on virtually everybody, 95%, and it's just mucosa alone and then closed transversely with a chromic closure, and that helps too. So I do all these things. And you got to say, oh, yeah, you mind? Well, the most recent thing I've added is a little lifting of the lip, but I do it only under the alar base, and it's small, as you can see, and it's done with a permanent furrow pulling, so you don't want to pull on the nose. It's got to be a deep stitch that holds that, and I've been doing that now. That's the most recent thing I've added in about 2/3. Occasionally, I'll put a permanent orthopedic type suture in to kick up the commissure, and I'll show you one case, but I don't really do that very often. But that was one successful case. Now, here's a stomopexy result long before I was fat grafting the lip. This is an old case. But again, look at the benefit that you can get when you elevate things. None of these have had the little thing under the nose. I'll show you those at the end, a few of them. But these are early cases just where the mouth has come up by doing any number of these various maneuvers, and you don't find out until you ask them to breathe through the mouth, not the nose. Then you get a reposed view, which also tells us how they're going to look when they talk. Same thing here with this woman. The coverage of the lower teeth is more important than exposing the upper teeth. What you do to the lower lip is more important than what you do to the upper lip. So, and again, any of this we want to get into, I'll be happy to elaborate on that. Lower teeth, lower pegs, the skinny pegs aren't pretty, the upper broad teeth are, and so that's important, even though it's a subtle facelift. But the power of the perioral result contributes significantly. She also had scleral show in that. Here's a young woman, 48, and we've left a very narrow upper lip because that's her signature, but we've given her a bigger lower lip and exposed her upper teeth, so she's rather like she was at 17 as a teenager. Here's that woman you saw before. But again, lifting the mouth position, the lower lip's more important than the upper lip, and we can maybe get some of that Memorex look. She looks almost like herself, and that's good. Here's a patient having a second facelift asking for a bigger lip. I'll give it a bigger lip if it's the lower lip she asked me for. If it's the upper lip, I won't. And so we help cover those lower teeth, and we give her a little something extra. And when you make a really big lower lip, but the most important thing in each of these is what we're doing at the commissure. When we make a big lower lip, be sure there's a central dent so it looks natural and it doesn't look like Oscar Myers. Again, an example here, the lower lip is overshadowed by the upper lip. Now it's the other way around. We reverse that ratio. Here's a woman with a very unfortunate aging of her features, eyes and mouth, and fat grafting is saved, contributed significantly, plus the lift of the mouth to both. But again, that's not a wonderful facelift result, but covering her lower teeth has helped her enormously. And it's just too bad that her surgeon didn't have more talent for her face. Here's one, again, where much more, you're not going to get worthwhile rejuvenation unless you've attended to the mouth in this woman. And I know we don't see these presented very often. Well, what's the conclusion you take from that? I don't know. Here's one who had a facelift and came in complaining in the corner of her mouth. So I put that orthopedic suture in, and she didn't show up for 3.5 years later, and there she is, and it worked out pretty well on her. But I don't advocate that, but I'm willing to use it under certain circumstances. There's a woman who doesn't look like anybody in the family anymore after her multiple operations, and she's the first one in which I lifted the nose onto the base of her nose. Has been heavily radiated, by the way. She's my first subalar lift. So this is a woman who, again, we've done a subalar lift. You can see her upper lip's a little shorter. Now watch her on repose when she relaxes, and it makes a big difference in terms of the way she presents in speech, as this one does too. And in a lot of these, you might say, well, you should have put more fat in these faces. Boy, if I put a drop more in this woman, I probably wouldn't be standing here. I'd be, who knows. But helping the mouth is very important. Here's a woman with a weakness after a prior facelift. It's a shame, of course. And you can see the right upper lip. But you can help these a little bit by doing asymmetric myotomy, asymmetric fat grafting. It's not corrected, but you can balance a little bit. And I'll show you a case in which I did that dynamically here in a minute or two. This woman did not have the subalar lift, even though she's quite older. She didn't want it, so we worked hard to get the best correction I could. And, she was 72 now and 73 now, and when she was young, she was a beauty queen in her country and all of that. So the mouth is just vitally important to our overall efforts. And the mouth many times dominates. It dominates in this woman's outcome. And in it, she saw her early self and really responded to it. And it just adds a quality to the thing. Now, the smile is the same. We can't change the basic personality of the smile. None of these patients can frown as well as they did because we've divided her DNA. Notice the weakness on her lip on the left. And notice how I've pretty well masked it by doing asymmetric fat grafting, asymmetric myotomy. And it's not completely hidden, but sometimes you can help it a little bit. I tend to see prettier smiles, as in this patient, but not always. And again, she can't frown as well. So how does that stack up? Well, I spend 70 minutes for the eyes when I'm not doing blepharoplasty, which, as I told you, I don't do very often. But I spend 65 on the mouth. I mean, on the mouth things, even though I'm including this thing under the nose, which I'm only doing 2/3. So I'm spending less time on the mouth than the eyes. And yet the mouth to me is more important than the eyes for most patients. So think about that. Now, I'm going to plea for maximizing our pictorial data during facelift presentations. This is the standard presentation for facelifts, and there's a lot of hair and their ears in there, and I'm not interested in any of that stuff. I just want to see what the surgical manipulation, unless the guy does hair too, maybe he does, I don't know. But I want to maximize the combined widths to get the most data, because I've got 63% more data on the left than I do on the right. And you can see the moles. Yeah, well, you can see that mole, but you might not notice the little moles. But more to the point, look at the difference in the disturbing eye. It doesn't bother you in the small image, but it bothers the heck out of you in the larger image. And Gulliver knew that when he visited Lilliput. All the people there in that little island with the little people had beautiful, wonderful skin and perfect complexions, and when he went to Brobdingnag, their skin was terrible. You could see every hair and telangiectasia and everything else. But despite that, I think we should be using Brobdingnagian images to maximize the amount of data that we present when it's hard enough with the rapidity with which we present. So you can see the subtle change in the lip. You can see the subtle movement in the under eye, things that otherwise I think probably escape our attention in the smaller image size. So that's just a plea of mine. Nobody will pay any attention. They don't pay any attention to anything else I say, but just for your information. So let's look at RSVP alone without fat grafting. And that's 75% of my patients. I'm going to do fat in the orbit and the mouth, and it's typically 25 cc's for those two structures. But in most, I don't do anything to the face or to the chin. So let's look at some examples of that. This is what I call architectural facelift. Here's a woman after it's a secondary. She's had prior surgery, and so 75% I don't add fat. And she'd had her surgery a year before, and her commissure and gel weren't helped by the surgery because the surgery was all posterior. And she had a dominant mouth as a young woman, and now she has more of that than she had before, and it's important to her recovery. Now, look at her commissure. It's so critical in so many patients, the architecture of the face. Well, she didn't have bad architecture, but it's better architecture now when we flipped her egg. And here's Millard, okay? Let's replace what is normal in normal position and retain it there. My mother said it better a couple years before. Put that back where it belongs, Bill. And that's what I do with the facelift. That pillow belongs back up there where it came from. And if you do that, you also do a whole lot of other things that you don't have to worry about, a lot of details of shape and all. And that just shows I didn't do anything to the neck. I made a claim that this surgery helps the low SMAS. I mean, the low SMAS and implantism, and it does. Now, I don't recommend no surgery for the neck, but I'll show you just a couple. Now, this woman again, let's see her architecture flip. You saw her commissure improve. And she's got an egg-shaped face now, ovate like Mary's egg. And how do we do it? Well, we lifted the pillow. And then, that's all. Put the pillow back at the head of the bed. That's all it was done to the face. Fat to the lids of the lips, always. Her mouth display is improved. Her nasolabial responds well. Her bitterness fold responds well. And she gets a shape that is cathedral-like in terms of those triptychs throughout Europe. She has Mary's egg, which is entirely appropriate. And how? Well, this time it wasn't the maid doing it, it was the poor old surgeon. But it doesn't make any difference who puts it back. Somebody has to put it back. And then when you put it back, it stays there a long, long time if you don't use tension. No fat added to the jawline. And so here she is, a young woman. She had an inverted cone of youth. Her eyes very similar, lips very similar, right down to the little depression in the middle of it. So that all makes a lot of sense. And then we want the upper lip to kick out. I don't want to thicken the upper lip, but I want it to kick forward. And of course, we got to help under the eye. And we lift her chin and everybody. And she's had no surgery on the neck below the mandible except liposuction. So lifting the jaw can help the platism a lot. Don't count on it. Stop doing neck surgery because you'll have a bunch of furious patients. But it's just interesting for you to see it. Now, she has a much better shape now once we've lifted her jowls up. Notice her eyes have opened. Her lower lip is important, and her commissure, of course, is going to respond. The commissure is just such an important part of my treatment of the face, and we're going to get her into an inverted cone of youth. Mary's egg, no fat, not a drop of fat's been added anywhere to her face. Where would you want to add it? I wouldn't. And again, I'll just show you no fat added to the jawline. It looked like maybe there was, it wasn't. And again, we want to kick out the lip. We want to take care of the suborbital deficiency. Lift your chin because chins tend to fall down with everything else that falls down. And in this case, no surgery below the mandible except the liposuction cannula. So here's a woman who had less fat than almost anybody in the last 10 years. And also, I didn't do myotomies on her. And yet she flips her egg simply by lifting her jowl up to the head of the bed. And nothing else, no sutures anywhere, no fat anywhere in the face. So it's quite powerful. You see, it's really quite strong. But you've got to undrape the face first to be able to reshape it. You can't do it and leave it intact. It can't be done. And now lip kicks out, filling under the eye with the minimal fat that she had. And she is an example of lifted her chin, which I do virtually always. She had one in which we simply put a suture in her platism, but didn't divide it, which I do, in about, 15%. She's got a lot of loose skin on this face, so I show her, again, the importance of wide undermining for me in terms of the correction of the redundant skin. And she's got a better facial shape now. When you look at her as a young woman, you'll see where she was headed in her age. You look at her nasolabial compared to what it is now in her 60s, and look at her under the eye. Look at her marionette that she had in her 31. So you know she was going to age like this. It was in the cards for her. But we want to address all of those things, and the skin excess is one of the many things that we want to be able to address. In terms of the architecture, again, without adding any fat anywhere, we've rearranged what fat stores are there. We've looked at what's fallen and put it back where it belongs, and that's all. And some of you would perhaps prefer a fuller face, and that's fine. That's personal taste, but it's not mine for most of these patients. And it looks like we've added to the jawline, but I haven't. And we kick out the lip always and fill under the eyelid always and lift the chin virtually always. And she also just had a strength put in her platisma. It's not perfect, but it's okay. Now, here's a very hard facelift, and that to me is as hard as facelift gets, and that's the effect of going through all that work that I do lifting the jowl. And I think it was successful in her, but it scares me that it might not have been in another patient with similar thick skin and thick fat. But it sort of worked on her, so I'm just going to show you a couple of subtle things and a couple of little twists. And she was a happy patient and felt it was a worthwhile return. Now her neck becomes doubly important when we do so little generally the face. So in this case, we're dividing the muscle as well as hitching up the muscle coat, lifting the chin, of course, filling under the eye and all because of what she had before. Now let's go on and look at this is a challenging case. And again, we've helped her commissures, very thick skin, heavy face. And again, you really pull out all the architectural stops to be able to convert this face into an inverted cone of youth. To be able to flip her egg, you got to have a pretty effective technique, I would suggest, and it was in her case. And you can see the improvements to the mouth as well. And I happen to know this woman. She was a beautiful young woman. I happen to know her through her much of her life, and she was quite stunning and beautiful with all of her wonderful blonde hair. But even now, looking at her early picture, she's got a better facial shape now than she had as a young woman. So that's a hard facelift. And this one too, look at all these lumps and bumps and everything. And here she is on her wedding day, many years before in a foreign country. And okay, and her face has just become very irregular and all that. Nothing's been done. The only fat in her face is in her lower lid, hardly a drop in her lip. And yet we've been able to flip her egg and get pretty extended curves back to this face without doing any manipulation to her volume except the one basic step of lifting this jowl up and doing the little tricks at the corner. Now she has had that little lip lift because you can see she got a little more display of her upper teeth, that thing just under the A-lip. Now that woman, of course, has big jowls and fat in the eye, but boy, she had good mouth position. We didn't need to lift anything there. But the mouth's prettier after surgery, and it should be after surgery. And you look at her facial architecture now, and it's really quite pleasing. And again, to follow up with the same theme, we talk about young and old and all that sort of thing. Just because you're 60 doesn't mean you can't be cuter than when you were 25. You can. She's a prettier woman in a maturity than she was as a young sassy 20-year-old. Now this woman, this is her right after facelift by somebody, and she hated the result, and she went out and found somebody, the dermatologist, to spend a year and a half filling her up with permanent fillers. God knows why. And look how much more the mouth has been pulled down in the process. You couldn't get anything out. You could hardly get a cannula into it. Nothing came back. So you take your best shot at a volume redistribution, which is what I did. And I told her it's 2 steps. This is her after step 1. And we don't have her back the way she was when she was very young, but the mouth's back to neutral, and her facial shape is much improved by moving this block of nasty stuff that I couldn't reduce 1 iota. So you need to have an architecturally effective procedure if you're going to take on something like this. And she now will get a little 15-minute relift of the skin with fat in the cheeks, since I've finally convinced her she doesn't want fat down low in the face, and we'll get a little further kick to things. This woman is subtle. She's only 44, and look at the basic rejuvenation she gets from this simple redistribution, fat to the lids and the lips, no place else. And I just make the point that the importance of the features, the eyes and the mouth in her outcome is enormous, and the little changes to architecture can be very powerful. She has the spark that she has when she was very young as a young mother, but maybe not the excessive cheek that she had at that time. So that's my story about those things. So I'm going to speak now a little bit, and so is Patrick, about fat grafting during facelift, because of course I fat graft during facelift. And these are the two that taught me about this. This was a sister who was extremely conservative, scared to death of facelift, so we didn't add a drop of fat to her face except her lids and lips. And she got you could argue a reasonable improvement. What particularly I show her for is to show that even though she doesn't have much jowl, she has some jowl. You can see it there. Her nasolabial improved, her bitterness fold improved. All those are always important, and that's part of my wide undermining. But when you look at the architecture of her face, we managed to flip that egg because she has enough in that jowl, not very much. Lifting that up into the submalar was enough to convert that. Now today, of course, I put some fat in her face as a part of my facelift, but I didn't on her. But her sister, who came to surgery 3 days later and was from out of town, this was this woman here, and she didn't have any jowl. So this is the first case I fat grafted during facelift. You can see the improvement to the commissure. You can see the change in her dental display, and you can see that's the mouth that she had as a young woman, much more like the mouth she had in the jawline that she had as a young woman. But I don't make claims when I put fat in the face, or I put implants in the face, or I put fillers in the face, which I don't make claims for architecture, because when you use those things, you ought to be able to get any architecture you want. So I'm not going to talk about architecture, but she had nothing in that jowl. So the only way I'm going to help her is to put some fat in. She's the first case I did in 2004, and it's only 3 cc's, and most of you would put more, and I probably would have put a little more, despite her great conservatism. So that started me off on fat in the face of the year 2004. And so I'll just share with you my thoughts about that, which I realize are not mainstream. Here are my volumetric manipulations of the face itself. I replace, and by that I replace the fallen existing fat to a higher location, usually from the jowl to the cheek, just as we saw in sister number 1. I call that architecture, and there's no volume added. Yeah, I do that in every 75%. Then I enhance some of them. And what I'm doing, I do that same replacement, but add to it volume into the cheek. Usually it's in the malar, submalar, and as I did in the sister, for 25%. And then, of course, I put fat throughout the face, pan-facial fat grafting, but on a case-by-case selective basis. It's not routine for me, and I do it a lot, but it's not routine. So how do I enhance faces when I put a little extra fat in the face? Well, that's what I do in 25%. Now, this woman is an example of somebody being overly thin with a lot of skin excess. Treating her features is very important to get these eyes and the strange mouth under control, but so too the face. And because she was early in my experience, of course, I underdid it. I didn't do as much, and she came back a year and a half later and asked for more fat, and we added some in the office. But this was only 3 cc's, and I think most of us doing fat grafting would add more fat to her face than 3 cc's I would today. But it helped her enormously, and it got her out of that sort of bizarre look into a more acceptable look. And again, nothing was done to her neck. I'll just show that she had no surgery below her neck, even though she's got a lot of loose skin. Her lip kicks out, and her lower lid fills. But then this is the effect of the lifting of the jowl on the neck and the platisma itself, without any additional manipulation of any kind. Here's another such example. Most of you would suggest that she's a little too thin too. And when you look at her early picture, sure. But notice that she has the characteristic of her early self. She suddenly isn't a woman with a larger face or a rounder face or anything like that. So she's overly thin. But this is modest fat grafting. This is 3 cc's total added to the face. And although I know many would want to see more fat, I do not, and she did not. And so we can do this with small amounts. Shakon awesome goo. And here's a woman with these staring eyes and all of that came in because she lost her cheeks. She said, I had big cheeks. Well, she's so thin, it's hard to believe. But when she brings a picture of herself, we put 5 cc's in her, which is a lot for me. But she brings in her picture. There it is on her wedding day. She has this great big cheek, even though she had this small, delicate face. Well, we left her face small and delicate, but given her the cheek. Thank you, Sydney. Fat grafting. So fat grafting is powerful in so many ways. Nothing been added to her jawline, of course. I just rarely do it unless I've screwed up. Here's a woman who says, well, I didn't mind aging, but I thought I'd stay prettier longer. And here she is, a young woman with a full lower lip. So we've given her a lip push, that a little bit push, the fat grafting a little bit, which for me is 5 cc's instead of 3 or 4, because of her concerns about lost beauty. Notice that in the lower lip is a good notch in the middle to keep it natural looking. Notice the improvement of the glabellar lines. Notice under the eye, all of that. And she takes on a softness and a feminine quality that she had lost someplace. And this is a similar category. But in her, I don't think it's a case so much of lost beauty, but maybe not the beauty that she might have wished for. She always had sort of a harsh face as a young woman, skeletal and all, and it takes on a softer tone with a small amount of fat. How much? 2.5 cc's. So we still lift everything, but 2.5 cc's to help the upper part of that malar curve, which wasn't going to happen by the lift of the jowl alone. So I've given that a boost, and there you have. What's her category? Well, she's masculine looking. So that happens to women sometimes to get into their 60s and all. And so because she looks so much like a man, I'm really pushing it. And for me, that's 5 cc's. Her commissure is way up. Her mouth is up. She's had a slant to her occlusal plane, but she's had that all of her life. She has the eyes and mouth she had as a young woman, but she looks like a woman now because curves are womanly, and she's lost the curve, and now she has it. And I certainly couldn't have done that, even though she has some jowl. I needed some extra help to convincingly, I think, feminize the result. So that's another example for me of the 25% in which I'm going to add fat to the face with that specific goal in mind. No fat added to the jaw in any of these, simply lifting the jowl. So what about non-routine fat grafting? Well, I do all of these. I just don't do them routinely. I do pre-jowl occasionally. I don't need it very often because if I've done my procedure right, I shouldn't need it. But if I need it, I'm going to put it there afterwards. The angle, I think it's not so much age-related until late in life, and it's extremely important for some patients, but not so often. And submental, I don't need to do it because I lift the chin on everybody, so I rarely have to put fat there. And I don't like fat in the upper lip proper because I think it tends to block smile, and much the same with the piriform. If I want piriform enhancement, I prefer the little Fanu silicone implant instead. And again, nasolabial, be careful about loading it up because we get blocked smiles. And the forehead, I don't do it so much because it takes so much fat, and you got to ask, do you really want how much gain do you get from it? If somebody needs it, sure. And I'll put fat in the submalar, but usually not if I'm doing a facelift because if there's a jowl, that will fill itself automatically. Now here are just some examples of some of those. Here's a woman who doesn't need a facelift, but like a lot of people from the Korean peninsula, she has a very strong bony zygomatic presence, and when these patients age, it can have a bizarre look, like an inartistic cheek implant or something. Simply putting fat in the submalar blends it and takes care of it. Our colleagues in South Korea, by the way, can reduce the bone, but that's so complicated. It's over the heads of all of us Occidental surgeons pretty much, but they do it masterfully. This is a guy looking all over the country to get balance to his face. He was almost ready to have, he focuses on it like young men do, asymmetries. He was all signed up for multiple unlay split rib grafts, which probably would have lasted 3 years. And fat does much better in this regard. Now, that's not perfect. This was an early case for me. It's done in the office under local anesthesia, but it's darn good. And he was pleased. He was satisfied. But today, again, I'd probably put a little more there. But you put fat wherever it's needed. It's such a wonderful tool. I just limit my routine use of it. Here's a woman who's had all the fat removed by 2 thermage treatments. So I had to interrupt her facelift because there was zero fat between her dermis and her masseter muscle. And I had to do a partial facelift, and it was hard for me to get the neck done. But that's an example of putting fat in the jowl. She needs it desperately. So you put fat where it's necessary. Notice the skin, giving credit to Sidney and his European colleagues and all about the effect of fat on overlying skin. And this is a guy who's a bit effete looking, like some of us of a certain age, and we can give him a more powerful look by leaving a submaxillary gland there and just filling in and giving him a heavier neck. Now, some people I seek to transform them. This is a woman who was having a abdominoplasty by me many years ago, and I said, your face is so thin, let's not throw away that abdominoplasty skin. So we made dermal fat grafts of it and put them throughout her face at the time of her facelift. And she's had a couple of little fat grafts since then, but she has no donor site. She's under 100 pounds. So she's aged well because of it. This is a very emaciated woman at 34, and she shows up at 44, and with these stable changes. Now, this is that woman I showed you to before who's very kind, but looks other than kind because of her mouth dynamics, and for whom I make the plea to get these at least back to neutral. But look how bizarre her facial contour was. She had an implant in place, and she had this and that. So this is a combination of course, getting rid of the implant, and this actually was included a second stage of fat grafting after facelift to get the contour back, because I could never predict how much absorption there's been in the malar bone when you take one of these long-standing implants out. This is just non-artistic surgery done elsewhere, and upper lip bigger than the lower lip. That's weird. Let's balance her upper eyelids, which have been raped of the tissue. Let's get her features back to what they were when she was a young woman, and get her back to looking at least natural. Maybe she can't be beautiful, but she can be natural at least. And she had these overbearing implants where we left the implants and treated her with essentially fat grafting alone. So of course, fat grafting is a savior for us all, and I'm preaching to the choir in that. We've seen such beautiful results all these last 3 days, and this is one with such a change. We want the patient to look like their daughter, not like the neighbor's daughter. Keep that in mind. And she doesn't look like a family member anymore, and now she does, because here she is as a young woman in her 30s. Except that at 63, she's a lot younger than she is in her 30s, with respect to a lot of the common age markers we all identify. But at least she looks like a family member again, and that's a good thing. So let's keep that in mind. And that woman I showed you before. But most of the fat grafting I do is rather limited. Here's an almost beautiful young woman, 31, in whom we put a little fat in the lids, lips, and the cheeks. And guess what? She's not almost beautiful anymore. Fat's a wonderful thing, and used in moderation, it does wonderful things. And almost everybody over a certain age needs it in their lids and their lips. I'm over 12 seconds, Jim. I apologize, but I'm going to invoke beauty is truth and truth beauty. And thank you on behalf of John Keats.